फर्स्ट ऑफ ऑल मैं थैंक्स करना चाहना हाँ नीमा कपूरथला ते आए हुए सब गेस्ट का ते इट्स अ वंडरफुल अपॉर्चुनिटी फॉर मी टू कम्यूनीकेट विद यू टुडे। पहली गल तो डॉक्टर अनमोल की जी प्रेजेंटेशन सी वो तो प्रॉपर रोलर कोस्टर राइड थी, मतलब एक्यूट स्ट्रोक मैनेजमेंट थे। सो माई टॉपिक इज़ ऑल्सो very common in the general population. The topic today is benign prostatic hyperplasia, which is BPH. So we'll discuss the symptoms and the management in core, and a little bit about the pathophysiology and the anatomy, of course. So my specialty is obviously urology. I practice andrology also, and the area of interest is kidney transplantation also. So some facts about the BPH. As the name indicates, it's a benign process. It's not malignancy as we discuss generally that prostate the cancer ho gaya. It's not like that. It's a benign pathology, and it is so common that is around 50% of the general population, which is more than 50 years of age, they have BPH, and about 80% of the general public who are above the age of 80 years, they have this problem. So what happens during BPH is why it is so interesting is that the prostatic hyperplasia, this pathology behaves differently in every individual. It's so unpredictable, its behavior, that some people would have some of the symptoms of benign prostatic hyperplasia and some will not, in spite of the fact that they have the same size of the prostate, they have the same age, they have the same socio-economic and the other backgrounds. And it is also interesting that many of those patients who have enlarged prostates, they may not have any symptoms, or they may have very mild symptoms and do not require treatment for whole of their life. And it is also interesting to know that the BPH, just the increase in size of the prostate, does not increase the chances of having prostate cancer in future. So this is the picture of the normal prostate. So this is the bladder. This is just the regular anatomy. We are all aware of it. So this is the bladder, and this is the urethra. And at the neck of the bladder, this tissue, this gland is the prostate through which the urethra passes. And on the right side of the diagram, this prostate is now enlarged. So you can see the urethra is totally compressed, obstructing the flow of the urine from the bladder through the urethra outside. So generally it is seen that the prostate is, if in a layman language I would say that it's of the size of a small lemon, which is near about 18 to 25 gram, or sometimes it is written as ml or cc in volume. So what happens during prostatic hyperplasia is that after the age of 50 years, there is a change in the hormonal milieu around the prostate, and because of that there is a generalized growth of the epithelial cells as well as the tissue around the cells, which is called as stromal tissue, and this leads to the compression of the urethra. If we exactly see in this diagram, this is what happens is, so this is the area of the bladder, and this whole tissue is prostate, and this is the urethra passing through the prostate. This outer purple color is the peripheral zone. This is the area where most of the prostate cancers develop, but now we are talking about the benign pathology, which is the BPH. And this yellow area, which is called transitional zone, or the periurethral area, this is where more than 75% of the BPH tissue grows, and this leads to compression of the urethra, leading to the symptoms and the complications. So what are the causes of BPH, and for the reasons for the development of the symptomatology that is related to it? So if I tell you honestly, we do not know the exact etiology. So what happens is, the most proposed theories are the changes in the hormonal milieu, which is imbalance in the testosterone and the estrogen levels, which happen around and after the age of 50 years. So there occurs accumulation of the DHT, which is dihydrotestosterone. This is the hormone which increases or induces the prostatic growth factors, which leads to increase in stem cells or decrease in stromal cells death. So this is what is known as development of the benign prostatic hyperplasia. So again, just to summarize and to show the difference in the pictorial way. So this is a normal bladder, and this is a normal prostate, and this is a normal urethra. So in BPH, what happens is the prostate tissue grows inside as well as outside. Outside, this is the capsule of the prostate, and because the capsule of the prostate is little rigid tissue, it is a fibrous tough tissue. So where this all grown prostatic tissue will go, this will go inside, means compressing the urethra, and this will bulge into the bladder. So this will again lead to obstruction to the flow of the urine from the bladder outside. So you can also see the difference in the wall of the bladder and the mucosa of the bladder. So what is happening here is, see, in the initial part when the disease develops, what happens is the muscle of the bladder, it involuntarily pushes the urine outside without the patient being even aware of it. So what happens is the muscle becomes hypertrophied, and the mucosa, it becomes trabeculated. There are channels, trabeculations in between the muscles, and the mucosa is pushed outside. So this is what I was trying to tell you, that the initial hypertrophy of the detrusor muscle, detrusor is the muscle of the bladder. So this leads to, over the period of time, over many years, what happens is that muscle gives up. So it becomes decompensated. So this leads to poor bladder tone. Bladder becomes flaccid. It doesn't contract properly. So this leads to diverticular formation. This leads to incomplete emptying of the bladder and increase in the post-void residual urine, which is a very important parameter when we evaluate the patients. We will be talking about this later also. So when this residual urine starts accumulating in the bladder, the pressure is put onto the kidneys, means the upper tract. Whenever we are discussing about the upper tract, we are talking about the kidneys, not the brain. So the pressure is put onto the kidneys, and the kidneys develop hydronephrosis, and eventually they fail. So again, when the urethra is compressed, difficulty in initiating the micturition, which leads to dribbling also, and the symptoms, most common symptoms are the frequency and the retention. This leads to bladder distension, eventually hydronephrosis and kidney failure. Increase in the residual volume in the bladder also precipitates infections. So when the prostate increases in size, many of the patients, they have symptoms. They are very subtle symptoms to start with, and they impair they deteriorate their quality of life. But some of the patients, they develop complications also. And what are the complications? So mainly the major complication that is associated with the prostatic enlargement is acute urinary retention. And this is the one most common urological emergency that we get calls from the emergency for. So acute urinary retention happens when by definition, the acute urinary retention is painful retention of urine. So the patient cries in the emergency and asks for the bladder to be relieved by any mean. And second common complication that we get is UTI and sepsis because of that UTI, and increase in residual urine obviously leading to infections, and incontinence. Incontinence usually in such cases is overflow incontinence. The bladder is full and the urine is flowing continuously outside. So over the period of time, when the residual urine in the bladder accumulates, it can precipitate stone formation also, and these stones can lead to hematuria and obstructive uropathy, eventually renal failure. The last line which I have written is hernia, hemorrhoid, bowel change habits. These all develop because of the voluntary or involuntary straining to pass urine out against the obstruction. So these were the complications that could happen because of the benign prostatic enlargement. But what are the subtle symptoms that are more common than the complications, for which the patient generally present to the outpatient clinic? So broadly, the symptoms of BPH, they are divided into two main categories. One is storage symptoms, which were the old terminology for these was irritative symptoms. Now they are called as storage symptoms. So a simple mnemonic is FU and fun. So frequency, urgency and nocturia. So nocturia is typically the most common initial symptoms which troubles the patient, and the patient comes to the urologist or the treating physician. So these are the storage symptoms, and they are more common than the other category, which is voiding symptoms. Older terminology was obstructive symptoms. So these symptoms I would tell you in the sequence of the process of micturition. Once the patient has to go to the washroom, they go there, they stand there, and they are unable to start urination. So this is called hesitancy. The patient would say, ਅੱਜ ਕਹਿੰਦੇ ਜਦੋਂ ਪੇਸ਼ੈਂਟ ਆਉਂਦੇ ਤੇ ਬਾਬਾ ਜੀ ਕਹਿੰਦੇ ਨੇ ਕਿ ਜੀ ਡਾਕਟਰ ਸਾਹਿਬ ਮੈਂ ਖੜਾ ਰਹਿਣਾ, ਪਹਿਲਾਂ ਮੈਂ ਜਾਂਦਾ ਸੀ ਬਹਿ ਜਾਂਦਾ ਸੀ ਜਾਂ ਖੜਾ ਹੁੰਦਾ ਸੀ ਤੇ ਯੂਰਿਨ ਫਟਾਫਟ ਸ਼ੁਰੂ ਹੋ ਜਾਂਦਾ ਸੀ, ਹੁਣ ਮੈਂ ਜਾਂਦਾ ਆ ਤੇ ਮੈਨੂੰ 2-3 ਮਿੰਟ ਲੱਗਦੇ ਨੇ ਸਟਾਰਟ ਕਰਨ ਲਈ, ਮੈਨੂੰ ਖੜੇ ਹੋਣਾ ਪੈਂਦਾ ਜਾਂ ਸੋਚਣਾ ਪੈਂਦਾ ਮੈਨੂੰ ਕਿ ਮੈਂ ਯੂਰਿਨ ਪਾਸ ਕਰਾਂ. So this is called hesitancy. And then in order to start micturition, they strain, they bear down to pass urine out. This is called straining. This is the other common symptom. They complain out. And once the urine starts, the stream of urine is weak. The typical saying by the patient is, complaint by the patient is कि डॉक्टर साहब मैं जो खड़ा होकर यूरिन पास करदा तो धार मेरे पैरों के कोल डिगदी है, कई बार पैर गिले हो जाते हैं या मेरी पैंट या मेरा पजामा जिहड़ा है वो भी गिला हो जाता है. So this is weak stream. So once the stream starts, it stops in between. So it is called intermittency or start stop. डॉक्टर साहब मैं पहला जाता सी तो मेरा एक या 2 वारी यूरिन पास हो जाता सी, ਹੁਣ मैं जाना आ तो मैनू ना 3-4 बार रोक के पास होंदा. रोक के word is very important. Intermittency. These are the typical symptoms of we will also discuss the differential diagnosis of BPH also. These symptoms are so typical of BPH that as the sequence, if you remember in the outpatient OPD, if you remember the sequence of voiding, you will pinpoint that this patient does not have the other differential, he has only BPH. So once the intermittency happens, then after completion of micturition, some of the urine dribbles out without the patient having any control on it. So this is called post-void dribbling. This is also an important symptom. And finally, the patient has a feeling of incomplete emptying of the bladder. Patient feels यार अजे होया नहीं पेशाब, so मैं आ गया कमरे दे विच बैठ गया, थोड़ी देर सोचा कि अजे होया नहीं, दोबारा जावां. So this is incomplete emptying. So these are typical symptoms of BPH and commoner than the complications of BPH. So these are the symptoms typical, but these symptoms can be there in other pathologies, other reasons also, because of the other reasons also. So what are the differentials of BPH? So common differentials are urethral stricture and then the bladder neck contracture. See, these two problems can be ruled out by careful history taking only. See, urethral stricture does not happen or does not occur in anyone without a prior history of UTI, urinary infection, or instrumentation or trauma or catheterization. You will have a history of prior hospitalization for which the patient was catheterized, during which the patient was catheterized, for example, orthopedic surgery. Majority of the patients who have hip transplants, hip replacements, or some major orthopedic surgery, they are catheterized at least once or twice. Then trauma to the pelvis or some instrumentation through the urethra, prior BPH surgery, which can precipitate the development of bladder neck contracture. So from history, these two important differentials can be easily ruled out. Then other cause of prostatic enlargement is 𝒖𝒄, prostate cancer. This can also be ruled out or at least detected early or easily by careful digital rectal examination only. Then advanced bladder cancer can also have irritative symptoms because the bladder is full of the tumor, the bladder is irritated, the symptoms can overlap with the symptoms of the BPH. Then stones in the bladder again will precipitate to the development of the irritative symptoms which can overlap with the symptoms of the benign prostatic enlargement. Simple cystitis, UTI, acute prostatitis can also have similar symptoms. And finally, neurogenic bladder. The behavior of the bladder in many neurological problems can alter. It can become, there are two extremes. It can become extremely overactive or it can become totally flaccid. So this is a spectrum in which the patient can present to you and can have symptoms which may overlap with the symptoms which are typical of benign prostatic enlargement. So majority of these differential diagnoses can be easily detected, ruled out or differentiated from BPH by just taking careful history and examining the patient simply by digital rectal examination or looking at the external genitalia. For example, as I told you, history of instrumentation or some surgery in the childhood, for example, surgery of hypospadias, after which the patient can develop urethral stricture. You can see the scar on the external genitalia even if the patient who has come now in 50s age may not remember that surgery in the childhood. So you can see the scar and find out that the surgery has been done, so he may have a stricture in the urethra. So now finally coming to the evaluation part. So we have discussed the symptoms, initially pathophysiology and the development of the symptomatology. So how do we evaluate the patient? So now we have in mind, after taking the history, that the patient may have some pathology in the prostate. So how do we evaluate? As we discussed earlier, careful history and careful focused examination of the genital external genitalia and internal genitalia is important. Focused neurological examination, why we discussed? Because the neurological urological manifestation of a neurological disease can have overlapping symptoms to the BPH. Then when we listen to the patient's symptomatology, what we do is we categorize these symptoms, we give them scoring system. We have a scoring system which is called International Prostate Symptom Scoring or American Urological Association Scoring System. These two are almost the similar kind of scoring systems. We'll be discussing them in the next few slides. So we give them scoring system. So how does this scoring system help us? We'll discuss this in detail again. This scoring system tells us about the severity of the problem patient has, how much the patient is bothered about his problem. Then third is examination, which is the most important part of the examination is digital rectal examination. So it is seen that up to 68% of the prostate cancers which are in stage 2 can be detected as early by the only digital rectal examination. No investigation is required. So the other important information digital rectal examination gives us about is the prostate size. In the initial days when ultrasound was not widely available, today it is told that transrectal ultrasound is the most precise investigation to know the size and the anatomy and even the internal anatomy of the prostate, but it is not widely available, or the expertise is not widely available for the transrectal ultrasound. Now, but the abdominal ultrasound has become more widely available. But in earlier days when it was not widely available, only the digital rectal examination used to be the #1 tool for assessment of the size of the prostate and need of surgery also at that time. So further investigation which are commonly performed as first line investigations in a patient with BPH are simple urine routine microscopy. Urine culture is plus minus, serum creatinine 100% to rule out damage to the upper tracts. And if the urine creatinine is not normal, then ultrasound of the KUB is recommended. We also measure the post-void residual urine. Doing a PSA is not mandatory, but it is said that in a patient who is 50 years old, presents with the symptoms relating to the prostatic pathology, doing a PSA should always be discussed with the patient. An educated patient should always be told, if he is more than 50 years of age, he should always be told about doing a PSA, at least a screening PSA. And it is true for a patient who has not even come with the symptoms of the prostate. Then important test is uroflowmetry, which will tell us about the peak flow levels and the pattern of the flow. How's the pattern? Looking at the pattern only can rule out urethral strictures and the other pathologies, other differential diagnoses that we just discussed. So this was the American Urological Association scoring system that we discussed. This is in detail, we don't need to go into the details. What we need to know about is that when we give score to each symptoms, there are 7 symptoms that we discussed, storage as well as the obstructive symptoms. When we give numbers to them, each symptom is given 0 or 1 number, and when we add them, if the total score is between 0 to 7, we classify them as mildly symptomatic, and 8 to 19 is categorized as moderate, and 20 to 35, which is the total score is 35, they are categorized as severely symptomatic patients. So this scoring system tells about the severity of the symptoms and the bother related to the symptoms by the patient. So one slide dedicated to digital rectal examination. Why? Because as I already discussed that it gives a very good assessment about the size of the prostate, and it can detect nodularity, which is typical of prostate cancer or the malignant process going on in the prostate. It can also detect cysts in the prostate, typically the midline cyst, which can typically have obstructive urological lower urinary symptoms. So we have discussed the pathophysiology, symptoms, evaluation, tests. Now we are coming on to the treatment part, which is very, very important now. So what are the indications to treat a patient? As in the first slide I said, not all patients who have an enlarged prostate, they need treatment. They do not. And why we want to avoid treatment is because there are medical treatments available, there are surgical treatments. Surgery is anyway becomes irreversible. Medical treatment is reversible, but medical treatment is not without side effects. It involves cost also. It gives anxiety to the patient. It has to be taken on daily basis. So we want to avoid treatment as possible, as much as possible. So what are the patient for the treatment, who need treatment? We need to select the patient who actually require treatment. So what are the absolute indications for the treatment? To start the treatment is severe obstruction. How we come to know about the severity? From the symptoms, scoring symptoms, and from the uroflowmetry. And the patient who go into retention even on medication, they require surgical treatment anyway. And the patients who develop renal failure because of the prostatic enlargement, they are the candidates who should be immediately treated, started on therapy. And the relative indication on the right side, patients who have moderate symptoms, whose score is between 8 to 19. And patients who have recurrent UTIs, at least 2 UTIs in 1 year, they classify for the relative indication to start a treatment, at least the medical treatment. Patients who have gross recurrent hematuria attributed to the prostate. See, if a patient has hematuria, we need to rule out the causes of hematuria and find out that whether this hematuria is only because of prostate or some other causes. If a patient has hematuria, patient should undergo detailed ultrasound of the KUB region to rule out pathology in the kidney, ureter and bladder, and then we attribute it to the prostate if no other pathology is found in the kidneys, ureter and the bladder. And if a patient is so much bothered that he has quality of life issues, he should also qualified as a candidate to start the treatment, at least medical. So what are the options for the treatment we have? See, as I said, not every patient requires treatment, not even the medical treatment. So what are the options? It has been seen and proven by various studies that patients with mild to severe symptoms, even if the symptoms are severe according to the scoring system, but they are not bothered. Suppose बाबा जी आउंदे ने, बाबा जी कहंदे कि बेटा इदां है भी मैं रात नूं ते 4-5 वार उठदा हां भी नॉर्मल बंदा तो नहीं उठदा 4-5 वार, हार्डली एक बार किते वो भी नहीं, रात नूं सौंगे तुसीं 11 बजे सवेरे उठे 6 बजे, रात नूं नहीं उठदे। बाबा जी कहंदे मैं 4 वार उठदा पर मैनूं कोई प्रॉब्लम नहीं, मैं रिटायर बंदा है, वेला हाँ, घर रहना हाँ, 4 वारी उठदा, नाले दरवाजा दरूजा देख लीदा है कि कोई आया तो नहीं, बड़िया तो नहीं आया, सब ठीक है, तो मैनूं कोई प्रॉब्लम नहीं। सो दिस इज़ अ टिपिकल पेशेंट हु डज नॉट रिक्वायर ट्रीटमेंट फॉर दैट. So he is not bothered. If he is happy waking up, he is okay. My job, our job as physician is to satisfy the symptoms of the patient and improve the quality of life. If his quality of life he feels that is good by even waking up 4 times in the night, I don't need to treat the patient. So what we can offer to the patient is something which has no side effect, which is called watchful waiting. Just wait, number 1. Do nothing and do little bit modification in your lifestyle. अपना बिहेवियर थोड़ा चेंज करना है, लाइफस्टाइल थोड़ी चेंज करनी हो, किदां कर सकते हैं वो भी ਅਸੀਂ थोड़ी देर छुने डिस्कस करांगे अगली स्लाइड ਦੇ ਵਿੱਚ. सो वाई ये क्यों इस तरह करना है, क्यों वेटिंग करनी है, क्यों ओनली लाइफस्टाइल मॉडिफिकेशन करनी है, वाई नॉट मेडिकेशंस? बिकॉज इट हैज़ बिन सीन दैट इन सच पेशेंट रिस्क ऑफ ट्रीटमेंट इज मोर देन द बेनिफिट ऑफ द ट्रीटमेंट. पेशेंट ਨੂੰ ਤੁਸੀਂ ਟ੍ਰੀਟਮੈਂਟ ਸਟਾਰਟ ਵੀ ਕਰ ਦਿੱਤੀ, ਉਹ ਤਾਂ ਪਹਿਲਾਂ ਹੀ ਹੈਪੀ ਸੀ, ਹੋਰ ਕਿੰਨਾ ਹੈਪੀ ਕਰ ਲਓਗੇ, ਪਹਿਲਾਂ ਹੀ ਹੈਪੀ ਹੈ। So इसलिए we don't need to give medication or offer surgery to such patient even if they have severe symptom according to the symptom score. And for those patients who are bothered with moderate to severe symptom scoring and who are bothered for their symptoms, they need actual treatment in the form of medicines or in the form of surgery. So first we'll discuss the what is watchful waiting and behavioral modification or the lifestyle modification. What we actually advise to the patient, what we tell them. बोल ਤਾਂ ਦਿੱਤਾ ਆਪਾਂ ਬੜਾ ਵਧੀਆ ਕਿ watchful waiting ਕੁਛ ਨਹੀਂ ਕਰਾਂਗੇ, ਪਰ ਕੁਛ ਤਾਂ patient ਨੂੰ ਅਸੀਂ advise ਕਰਦੇ ਹਾਂ। ਉਹ ਕੀ advise ਕਰਦੇ ਹਾਂ? We tell them to decrease intake of caffeinated drinks. ਚਾਹ ਕੌਫੀ ਘਟਾ ਲਓ ਜੀ। ਅਗਰ ਤੁਸੀਂ ਚਾਹ ਪੀਂਦੇ ਹੀ ਹੋ ਤੇ ਤੁਸੀਂ ਚਾਹ ਜਿਹੜੀ ਸ਼ਾਮੀ 5-6 ਵਜੇ ਤੋਂ ਬਾਅਦ ਨਾ ਲਓ, ਉਹ ਤੋਂ ਪਹਿਲਾਂ ਹੀ ਫਿਨਿਸ਼ ਕਰ ਲਓ। Because the diuretic effect of the caffeine will come after 45 minutes and ਹੌਲੀ urine ਬਣਦੇ ਰਾਤੀ 9 ਵਜੇ ਤੱਕ bladder full ਹੋ ਜਾਏਗਾ, ਫਿਰ ਰਾਤ ਨੂੰ ਜਾਂਦੇ ਰਹਿਣਗੇ। So it is better to finish off their tea, coffee in the early hours of the evening. Avoid excessive alcohol because it also has diuretic effect, वो नहीं लो। And if you are planning to have alcohol on particular day, तो ਮਨ ਨੂੰ ਇਹ ਸਮਝਾਓ ਕਿ ਅੱਜ ਤੁਹਾਨੂੰ symptom ਥੋੜੇ ਜ਼ਿਆਦਾ ਹੋ ਜਾਣਗੇ। ਸੋ ਉਹਦੇ ਨਾਲ ਸੈਟਿਸਫਾਈ ਰਹੋ, ਰੱਬ ਦੀ ਰਜ਼ਾ ਦੇ ਵਿੱਚ ਸੈਟਿਸਫਾਈ ਰਹੋ ਅਗਰ ਤੁਸੀਂ ਕੁਝ ਲੈਣਾ ਹੀ ਹੈ ਗਲਾਸ ਤਾਂ। ਸੋ ਇਹ ਪੇਸ਼ੈਂਟ ਨੂੰ ਸਮਝਾਉਣਾ ਬੜਾ ਜ਼ਰੂਰੀ ਹੈ, ਸੋ ਦੈਟ ਪੇਸ਼ੈਂਟ ਡਰਿੰਕ ਕਰਕੇ ਐਂਸ਼ੀਅਸ ਵੀ ਨਾ ਹੋ ਜਾਏ ਕਿ ਮੈਂ ਡਾਕਟਰ ਸਾਹਿਬ ਡਰਿੰਕ ਕੀਤੀ, ਮੈਂ ਬੜਾ ਪਰੇਸ਼ਾਨ ਹੋਇਆ। ਅਗਰ ਉਹਨੂੰ ਬੈਕਗਰਾਊਂਡ 'ਚ ਪਤਾ ਹੋਏਗਾ ਪੇਸ਼ੈਂਟ ਨੂੰ ਕਿ ਅੱਜ ਮੈਨੂੰ ਸਿੰਪਟਮਸ ਹੋ ਸਕਦੇ ਨੇ, ਤਾਂ ਵਿਲ ਬੀ ਮੋਰ ਸੈਟਿਸਫਾਈਡ। ਦੈਨ we tell the patient to avoid having large quantity of liquids in one time. For example, ਕਈ ਵਾਰ ਪੇਸ਼ੈਂਟ ਹੁੰਦੇ ਨੇ, ਆਦਤ ਇਹ ਹੁੰਦੀ ਹੈ ਕਿ ਡਾਕਟਰ ਸਾਹਿਬ ਮੈਂ ਸੌਣ ਤੋਂ ਪਹਿਲਾਂ ਨਾ 3 ਗਲਾਸ ਪਾਣੀ ਜ਼ਰੂਰ ਪੀ ਕੇ ਸੌਣਾ। ਹਾਂ, ਮੈਨੂੰ ਕਿਸੇ ਨੇ ਦੱਸਿਆ ਕਿ ਕਿਡਨੀਆਂ ਸਾਫ਼ ਰਹਿੰਦੀਆਂ ਨੇ, ਬਿਲਕੁਲ ਫਿਲਟਰ ਹੋ ਜਾਂਦੀਆਂ ਨੇ, ਸਾਰੇ ਦਿਨ ਦਾ ਖਾਧਾ ਪੀਤਾ ਸਾਫ਼ ਹੋ ਜਾਂਦਾ ਆ, ਸਵੇਰੇ ਉੱਠ ਕੇ ਵਧੀਆ ਪਿਸ਼ਾਬ ਕਰਾਂਗੇ। ਪਰ ਮੈਂ ਤਾਂ ਬੜਾ ਪਰੇਸ਼ਾਨ ਹੋ ਗਿਆ ਉਹਦੇ ਨਾਲ। ਸੋ ਵੀ ਨੀਡ ਟੂ ਟੈਲ ਦ ਪੇਸ਼ੈਂਟ ਟੂ ਅਵੋਇਡ ਹੈਵਿੰਗ ਲਾਰਜ ਕੁਆਂਟਿਟੀ ਐਟ ਵਨ ਟਾਈਮ। ਯੂ ਕੈਨ ਹੈਵ half glass now, 2 hours later half glass, is tarah, and that too in the day hours, in the light hours, not in the dark hours. And other thing is we should tell them to go to pass urine as early as they have an urge to pass urine. Do not hold nahi karke rakho baba ji, tusi jaldi jao te pass kar lo urine, so that the bladder unnecessarily does not get hypertrophied. जो हम आप image देखी सी bladder दी, वो image ना बन जाए। And then we tell them to avoid such chemicals or such food materials which are irritant to the bladder. For example, especially tobacco, smoking, it is irritant to the bladder and can precipitate symptoms, can exaggerate the symptoms of BPH if you are more than 50 years of age. Artificial sweeteners and carbonated beverages, for example Coke, Pepsi हो गया या soda हो गया। And then again almost a similar thing, night time fluid consumption should be reduced, and it has been seen by this technique, by this method, only by behavioral modification, 1/3 of the patient they have improved symptoms over the course of few months. They do not require any treatment. So moving on to the actual management, actual intervention part of the treatment, which is now the medical management. We will discuss later the surgical, now the medical management. There are mainly two components. The first one is basically a component from a plant which is called 𝗕𝗲. It has been used and there are various studies on this. I have used it personally also on with some patients with good advantage. In patients who had actually side effects with the other medications which I am going to discuss, I use this medication with good results. But not many studies are available. Data are there, but not many studies. So classical drugs and the most common drugs, I would say the staple of the medical treatment of BPH are the alpha blockers. Initial alpha blocker doxazosin and trazodone now are rarely used. Commonly used alpha blockers, the most common one is tamsulosin, alfuzosin, and silodosin is the newer drug which has come in the market. It has been now around 10 years since the silodosin has come. Second class of drug is 5-alpha reductase inhibitors, and the two most common available drugs right now in India are finasteride and dutasteride. They are rarely used as single agents. They are generally combined with alpha blockers. We will be discussing about the strategies to combine these two drugs. And the third technique which we use is combination therapy, alpha blockers and 5-alpha reductase inhibitors combined, and how and when to use I will be discussing in the next slide. So, little bit about the benefits, I mean the advantages and the disadvantages of the medical management for BPH is, number one, medical management is convenient. Convenient for most of the patient. Why? Because patients sometimes get afraid by the name of the surgery. डॉक्टर साहब जो मर्जी हो जाए, ऑपरेशन नहीं कराना, जो मर्जी दे दो मैनू, दवाई मैं जो कहोगे खा लांगा, जितनी मर्जी महंगी होवे जी. So convenience for the patient, just a medication, just a tablet has to be taken. No loss of work, patient doesn't need hospitalization for medication. OPD चाहे दवाई ले घर चले गए, even Sunday OPD is open now, come and दवाई ले घर चले गए, कोई work loss नहीं है. And risk, all the side effects are there, but there is minimal risk. If we compare it to the surgery, the risk is minimum. But there are advantages also. Number one, cost involvement. See, on an average, monthly expenditure for the BPH medical therapy comes between 1200 rupees to 2000 rupees per month. So the original molecule है जो डॉक्टर रेडीज दे हैं या ओरिजिनल मॉलिक्यूल्स जिन्हें सन फार्मा ने बनाए हैं कुछ, वो even costlier है. So cost is involved, number one, and that cost has to be nearly lifelong. This is a very common question asked by the patient that डॉक्टर साहब कितनी देर दवाई चलेगी. So if I tell you honestly, there are no studies presently which are done only on stopping the medication after 2 years or 3 years. This is one strategy which we use in practice, but there is no backing of data on this. So we generally tell the patient that nearly lifelong medications. We can try stopping the medication after 2 to 3 years in stepwise manner, but majority of the patient would require medical management for their life. So number one is cost involvement for life. Number two, these drugs can interact with other drugs which the patient is taking, especially the drugs for the cardiac medication. Majority of our patients with BPH are elderly patients. They might be having hypertension, coronary artery disease, on multiple other drugs, antihypertensives. So these drugs have interaction with the cardiac and antihypertensive drugs, and even drugs for the renal failure. Third one is, tablet has to be taken on daily basis, every day. Till today, there is no medication which can be taken on weekly or twice a weekly basis. Medication has to be taken on daily basis. Even if a patient skips a medication for 2 days, मैं पुराने चला गया सीगा, वनडियां दे गया उत्थे 2 दिन मैं दवाई डॉक्टर साहब डब्बी घर भुल गया, मेरे तो पेशाब रुक गया उत्थे. This is a very common scenario which we face in the OPD. So 2 दिन दवाई नहीं ली, तीजे दिन symptom reoccurrence. Then the issue with the medicine is it does not treat the pathology, it just alleviates the symptoms. Prostate is there only, it is not going to go anywhere. दवाई बंद, symptoms दोबारा. So it does not treat the pathology, it just manages the symptoms only. So coming to the individual class of drugs. So alpha blockers, as I said, most common drugs used for the treatment of BPH. What they do actually? They what they do is they, as we remember that picture in which the urethra is compressed by enlarging prostate gland. So what they do is they relax the muscles in and around the prostate. By that they dilate the urethra, and that is why they improve the urinary flow. The stream of the urine improves. ਜਿਹੜਾ ਪਿਸ਼ਾਬ ਡਾਕਟਰ ਸਾਹਿਬ ਪਹਿਲਾਂ ਡਿੱਗਦਾ ਸੀਗਾ, ਮੈਨੂੰ ਮਹੀਨਾ ਹੋ ਗਿਆ ਦਵਾਈ ਖਾਂਦੇ ਨੂੰ, ਹੁਣ ਉਹ ਥੋੜਾ ਦੂਰ ਡਿੱਗਣ ਲੱਗ ਗਿਆ, ਖੁੱਲ ਕੇ ਵੀ ਆਉਂਦਾ ਪਿਸ਼ਾਬ. These two statements signify improvement in the urinary flow. But there are side effects, and there are important side effects of these drugs, alpha blockers. What they do is the most common side effect and most troubling side effect experienced by the alpha blockers by taking alpha blockers is retrograde ejaculation. And why this is important is because this is a disease of men. So being when men they do not experience ejaculation, it is correlated that their manhood is gone. So for some, at least many patients, this can be a very, very troublesome side effect. Why this happens? Again, because of the dilatation of the urethra and opening of the involuntary sphincter which is located at the bladder neck. So what happens to the semen? It goes back into the bladder whenever the ejaculation happens. It doesn't come out. And this side effect is very common. This happens between 35 patients to 95% patients who are taking alpha blockers. Other common side effect is postural hypertension, orthostatic hypotension. That is why we usually give this medication at bedtime only. Take the medication and go to bed. Dizziness, again almost similar because of the postural hypotension, and fatigue. Next day, fatigue, backache, myalgia is very common. And for a patient who is working even in this age, physically working है, ਉਹਦੇ ਲਈ थोड़ा ये medication लेना can be troublesome side effect हो सकता है, fatigue. Then as I already discussed, drug interaction, especially with antihypertensive and cardiac drugs. So little bit about the profile of the individual alpha blockers. Almost all these alpha blockers, 5 alpha blockers we discussed, doxazosin and trazodone now are almost out of date. They are not being used in clinical practice. So tamsulosin, silodosin and alfuzosin, commonly used alpha blockers, almost they have equal clinical effectiveness once used for more than 5 days. After 5 days, almost equal effectiveness hai. So difference किथे है? Difference is slightly in their side effect profile, slightly in their interaction. For example, ejaculatory dysfunction, retrograde ejaculation, severest ejaculatory dysfunction happen with silodosin. Almost 95% of the patient would experience retrograde ejaculation, they would not ejaculate. Tamsulosin second, and alfuzosin is considered the drug of younger patients. Why? Because this the incidence of retrograde ejaculation is less than 25%, so ejaculation is preserved. So drug of younger patient, ejaculatory preserving drug alfuzosin. We tend to give it into the tend to use it in the younger patients who have come for the treatment. Then hypotension is to be considered lower with tamsulosin. So these are the side effects which guide us for choosing a particular agent for a particular patient. Then the difference is in the decreased energy level, because the silodosin is now considered the most efficacious alpha blocker available for BPH till date. Initially it used to be tamsulosin, and if you see actual efficacy, it has been shown that silodosin is 160 times more efficacious than tamsulosin. But in clinical studies, these are the lab studies. So, but in clinical, when you use them in the patients, actual patients, after 5 or 7 days, the efficacy is almost equal. So, where we prefer silodosin is, number one, when the patient has acute urinary retention. You put the catheter and you start silodosin. Patient will have immediate effect within 36 to 48 hours. You can even remove the catheter on 3rd day. I mean, you can attempt to remove the catheter on 3rd day. With tamsulosin, the peak effect comes in 5 to 7 days. So, where you need faster effect, you give silodosin, and after 5 to 7 days, the efficacy is almost the same. Other advantage of silodosin is it is safer in cardiac patients. Tamsulosin, it is safer in kidney failure patients. Many patients, BPH patients, are CKD patients. There we tend to use tamsulosin over silodosin. And alfuzosin, as I already said, in younger patients. Coming to the next class, 5 alpha reductase inhibitors. How do they work? What they do actually? As we discuss alpha blockers, they dilate the urethra, improves the flow. So what 5 alpha reductase inhibitors, finasteride and dutasteride, do? They reduce the prostate size by around 30%, but if taken for 6 months or more. They have to be taken for 6 months or more in order to reduce the size of the prostate by around 30%. They do not reduce the size more than that. How do they work? They block the conversion of the testosterone to DHT, which we initially saw that is required for growth of the prostatic tissue. Problem with them is they do not work immediately, have to be taken for longer periods, and they are only beneficial if the prostate size is more than 30 to 40 cc. So what are the adverse effects? When they reduce the DHT, the side effects is decreased libido, sexual interest is gone, erectile dysfunction happens, erection problems they occur. So that is why we do not want to use them where they are not required. Unnecessary adding tamsulosin with dutasteride is not required. We immediately tend to give silodosin D, tamsulosin D lelo. It is not, has to be added very, very cautiously in, for example, 50 to 60 year male who you think that may be very sexually active. You don't want to give them dutasteride because they will lose their sexual interest. You lose interest in your physician also. They would come back. So gynecomastia is another problem with 5 alpha reductase inhibitors. However, it has been seen that they reduce the chances of patient going into retention when they are started. So combination therapy, as I already said, it is usually used when the gland is larger, 30 to 40 cc, and is generally preferred when the patient is at significant risk of progression or developing the complications. And who are these patients? These are the patients who have retention with more than 1 liter of urine in their bladder, with age more than 70 years, and who are diabetics. These are the patients where we tend to use dutasteride, because they are high risk patient for going into retention or developing complications. Again, the gold standard care, no surgical treatment has demonstrated better outcome than TURP. So what are the benefits of TURP? It is now generally everywhere available. Even in a smaller city, smaller set of TURP is everywhere available. More effective than drugs, and you can stop the drug after doing TURP. No need of drugs to be taken after TURP, and lifelong lasting effect after TURP. It is a one-time treatment. So disadvantages, mainly the surgical complications can happen, which are not chronic complications. Hospitalization, obviously it is a surgery, hospitalization is required. Catheterization up to 48 hours is required. Overall recovery takes around 1.5 months. So what are the complications? Initial complication, significant complication which can happen is bleeding and patient going into clot retention because of the clot blocking the urethra. This would require another operation. And there is around 5% risk of patient having intractable irritative symptoms for life and development of bladder contracture and UTIs. The chances are less than 5%, but these can happen. Incontinence is very, very rare because of sphincter injury. It has been seen that there is slight erectile problem after TURP, around 3% incidence, and retrograde ejaculation is around again 65 to 95%. See, retrograde ejaculation is one side effect which will happen with any form of treatment you give, except watchful waiting. If you are not doing anything, this will not happen, but otherwise this is bound to happen. So little bit about the post-operative care. Continuous irrigation, as we all know, after TURP, post-op irrigation usually for 24 hours. Blood clots clear होते रहते हैं. Catheter is usually removed after 48 hours, and after that we do Uroflow and PVRU after 1 week, not immediately after catheter removal. I personally prefer to advise patient doing Kegel exercises or pelvic floor muscle exercises in order to strengthen the sphincter for early and better control and avoid minor leakage that can happen after TURP. Laser, it has been seen that after 7 years, symptoms improvement and parameter improvement is almost similar to the TURP, and it can also be done in patients who are on anticoagulants. There is no or minimal risk of bleeding. So to summarize, see, the patient with LUTS, low urinary tract symptoms due to prostate enlargement, they should be properly examined and evaluated, rule out other causes. And it is very, very important to select the patients who require treatment and avoid unindicated treatments. It is better to explain the side effects of the treatment to the patient so that they don't unnecessarily get anxious and withdraw from the treatment. Surgical treatment, mainly TURP, is now widely available. Thank you very much. I am so sorry for a very long, I would say maybe a little boring, but it was a common topic. So I tried to include everything which was the common doubts I wanted to clear actually. Thank you very much.